Hello, online students. I'm going to try, this is my fourth time, maybe fourth time's a charm, to do the structural defects. For some reason, this PowerPoint's not communicating with the upload when I go to upload it to YouTube, but hopefully it'll work this time. If you would, make sure you've got your Peds book out again, and if you'll turn to page 800, that's where we're going to be getting started. I've got a dry throat from trying to record it so much. One thing about it, I know the content well. All right, so I'm going to get off here now. It was good seeing all you guys. All right, pull up my PowerPoint. All right, we're going to be talking about structural defects, and mainly we're going to focus starting on cleft lip and or cleft palate. And these are both facial malformations that appear separately, but actually more commonly they occur together. Usually you have the lip and the palate distortion together. If you look at the cleft lip, it occurs between the 5th and 8th week of gestation, so very early on. And it results from failure of the maxillary and median nasal processes to fuse. Cleft palate results from failure of the two sides of the palate to fuse between the 7th and 12th week of gestation. So both of these are occurring very early on. Incidence, you can see here, this is supposed to be cleft lip, cleft palate is 1 in 1,000 live births. Cleft lip's more common in males, cleft palate in females, and then we see it more in our Orientals and our certain Native American groups as well. Etiology, there is a genetic familial pattern, about up to 5% risk with other pregnancies. They have linked it to certain medications, dietary factors, folic acid, vitamin defects. And most recently, research supports that excessive maternal intake of alcohol and in smokers. In fact, it's been found twice as common in women who smoke during pregnancy. Cleft lip may be unilateral or bilateral on one side or both sides, and with varying degrees of severity. It can be just a small indentation in the vermilion border to all the way up through the nasal passages. But one of the big things you're going to have to concentrate on is teeth malformations. And these often occur with this defect, either too many, they're malformed, or absent teeth. So this is a major long-term problem. Again, it can be anything from a notch in the vermilion border to unilateral cleft lip, cleft palate, to bilateral cleft lip, cleft palate, to just cleft palate. And I've given you a good website that you can go to and look at these helpful pictures. Now, if you look on your book on page 800, it does show you a picture of cleft lip repair at 16 weeks. You can see there he's got the elbow restraints on that I'll be talking about in a little bit. Please note those need to be taken off and check for reddened areas, and they do have to keep those on at all times. You'll notice that he's laying on his back, which is going to be common because you wouldn't want them laying prone because they could mess with those sutures and interfere with healing. And then look 3 weeks later after surgical repair. So you can see we are doing some wonderful things with cleft lip, cleft palate repair. Again, it is going to require also a number of specialists, and it is apparent at birth. This is one of the reasons that nurses that work in the OB department need to palpate the palate all the way back as part of every newborn examination, because a lot of times they're just small and they get missed. All right, treatment is surgical correction for cleft lip. Repairs done first over palate. And there's two theories here. Some say do it shortly after birth, and some say wait 6 to 12 weeks. So there is a controversial. So what are the issues here? Well, those that say at birth, it's because of the feeding difficulties they know they're going to face and the likelihood that they may not gain enough weight for surgery and have nutritional problems, therefore not do as well during surgery. For those who say wait 12 to 6 weeks, they say by that time they're more stable, and really they'll kind of sometimes even go by the rule of tens. At least 10 weeks old, weigh 10 pounds, and have a hemoglobin of 10. So sometimes they even go by the rule of tens. 10 weeks, weigh 10 pounds, and hemoglobin of 10. The goal, no matter what, is to close that defect and achieve a balanced, symmetrical appearance. Okay, post-op care of the cleft lip, and well, immediately after surgery, we've already talked about them. They're going to have um, a thin metalled arch, or they're going to have a butterfly type adhesive restraint. And again, if you look on page 800, that shows the example of the butterfly type adhesive restraint. So the Logan would just be metal arched instead of adhesive. The arms again have to remain strained at the elbow, so you want to remember that when you're providing distractions and trying to soothe the child. Also, you don't want them crying a lot because you don't want to putting a lot of tension on that. Surgical correction for cleft palate, on the other hand, is postponed. The preferred age for this procedure is 12 to 18 months. Now, some books say 6 months up to 2 years, but 12 to 18 is basically the preferred month. And it really depends on the defect and the type of severity and problems they're having with speech. So why are we doing this? Well, the main reasons is to take advantage of the changes in the palate that's going to occur with normal growth and development. The main reason is to take advantage of the changes in the palate that occur with normal growth and development. Otherwise, you could repair it too early, and then the mouth's growing a lot and you end up having some issues. Nursing considerations, pre and post-op teaching. The immediate problem again is going to be feeding. And if you'll just Google pictures and images and bottles used to feed children or infants with cleft lip, cleft palate, all kinds of bottles will pop up, and that will give you a good visual of some of the types. As far as otherwise, if you look on page 801, it also talks about feeding difficulties on that page, and if you'll read that, it will help you understand it a little bit better. Support emphasis is on the positive of the infant and letting them know that repair now usually has very good outcomes. And most people in a lot of the OB departments have before and after pictures that they show new parents to show them that, healing does occur quite well, like the picture in 800 in your book. Genetic counseling, which should also be made available. Feeding cleft lip or cleft palate decreases the ability of them to suck. And if you can't suck, then you're not going to get the required nutrients that you need. So with that, a normal nipple will not work. They have to have an orthodontic nipple, the one that's got a wider base with a larger slit at the end. So a regular nipple will not work. In both, liquid in the mouth will escape via the cleft through the nose, so you got to feed them in an upright position, burping a lot, special nipples, and feeding devices. For the most part, we use the ESSR method. The ESSR method. E stands for enlarge the nipple. Enlarge the nipple. S stands for stimulate the suck reflex. If you try to get that stimulated before you put it in there, sometimes that will help and decrease the effort of sucking. Stimulate the suck reflex. The other S, swallow fluids appropriately. Make sure they are swallowing, because if you've got it further in their back of their throat and you've got a larger slit in it, they can choke. And R is rest. Rest. When the infant signals they need a rest, let them rest. That's the ESSR method. Now, they can also be fitted for prosthetic palate coverings known as arbitrators, and those are good, but they're very expensive, so sometimes insurance does not cover them. And they're going to have several fittings over time, so it's not a one-time fit. So another problem with insurance, because it's a lot cheaper to use the bottles than it is to get the arbitrators. The nipple is positioned in such a way that it compresses the infant's tongue and the existing palate. Again, burping frequently is needed. Breastfeeding is an option, but it is difficult. But you still should allow that option and explore options and let them have information that will help them make an informed decision. And pumping is always an option as well. Especially with cleft palate, sometimes they have to work twice as hard to obtain the milk than the actual calories that they consume. And here we are wanting them to gain weight prior to surgery, so that can be an issue. Cleft lip, a pre-op feeding, getting them used to lying on their back or side, because post-op you will have to. And why do we have to do that? because we want to, again, avoid trauma to the lip. So they need to be, if they are on their side, it's just slightly on their side if they can't tolerate supine, but you don't want them prone by no means. If you put them on your side, you also want to watch them carefully because they could still rub that side. So the best position is supine, on their back. Post-op, incisional site care, pain relief, protect incisional site, elbow restraints, like we talked about earlier, minimizing crying, and like we talked about earlier, making sure we remove those strains. They still need cuddled, they still need oral care, and they still need to be upright when they're feeding. Usually after cleft lip, we're going to use like brick feeder, and if you don't know what that looks like, again, all you got to do is Google images and it will show you an image of a brick feeder. It's a large syringe with a soft rubber tubing, and they will usually use that syringe for about 7 to 10 days after repair. 7 to 10 days after repair. Now, cleft palate, they're going to be lying on their abdomen, and with, of course, their head on their side. You don't want their face prone. So on their abdomen, head to the side. Now, why are they that way? That prevents aspiration post-operatively. Because if you think about it, they're going to have a lot of drainage going down the back of their throat. So that's to help prevent aspiration post-operatively. They're going to resume feedings. They're going to have a packing for 2 to 3 days. They're going to be in elbow restraints as well. And it's going to take longer for them to heal, 4 to 6 weeks to heal completely. So they are also going to be fed with the brick syringe anywhere from 7 to 60 days. Anywhere from 7 to 60 days, depending upon the extent of the cleft palate and how much repair they had to do. Now, when they get discharged, they're going to be discharged on a blended soft diet, no harder than mashed potatoes, and that just allows even more time for healing and will be advanced as the physician orders. Nursing alert. Nursing alert. Avoid the use of suction or other objects in the mouth, such as tongue depressors, thermometers, spoons, and straws. Someone's done it. Even with repair, nasal distortions are common 10 to 20% of the time. They even have learning disabilities. So even with repair, nasal distortions are common, and up to 10 to 20% have learning disabilities. Resources out there, there are some resources: Cleft Palate Foundation, American Cleft Palate, and About Face. All right, if you have any questions about that content, please get in touch with me. All right, what about esophageal atresia, also known as EA, with a tracheoesophageal fistula, also known as TEF? This is congenital malformations that involve failure of the esophagus to develop a continuous passage, therefore atresia. Esophageal atresia does not connect all the way through. Or a TEF, which is a fistula, and it's a fistula that's present that forms an unnatural connection with the trachea. So there's a fistula between the esophagus and the trachea. This occurs in utero, 4 to 5 weeks gestation, about 1 in 4,000 live births, and etiology is unknown. It has been known to be more common in preterm infants and low birth weight infants. So if you'll turn to page 803 in your book, that will help us. So if you've got a parent who's been feeding the baby and they constantly complain, you know, every time we feed this baby, they're turning blue, they're coughing, they're choking, they got a lot of saliva in their mouth, huge red flags for TEF. And we'll talk about the 3 C's here in just a little bit that you look for that I just described. So there are actually over 96 variations. You'll be glad to know I'm going to only have you know the top 5. A, B, C, D, and E. The most common type is C. The most common type is C. So just to review again, if you see EA, that's esophageal atresia. That means the esophagus is not completely formed and ends in a blind pouch. TEF refers to either a proximal and or distal connection between the esophagus and the trachea. So there's a fistula between the esophagus and the trachea. All right, so let's look on page 803 in your book and follow along. First one is a type A, and a type A is an EA, esophageal atresia, without a TEF, so there's no fistula. This is our second most common type, 5 to 8%, and it involves an EA only. Although there's no TEF to cause gastric juices to reflux back into the trachea, they still present with respiratory distress, because if you look on page 803, you can see there the esophagus is not a continuous tube. It actually comes into a blind pouch there. And because of that, the accumulation of all that saliva in the esophageal pouch is going to cause aspiration. So that's a type A. A type B is an EA with a TEF proximal. So if you look at the figure on page 803, you can see we still have our EA. It's a blind pouch and it's not connected. But now we have a fistula also between the esophagus and the trachea, and it's proximal, or on the upper part. So now if you look at that, these children need meticulous attention, because now we need to prevent the aspiration of saliva from the pouch, because any secretions that's going to go in there is also going to go across that fistula into the trachea. So we have to watch these children for respiratory distress. Now a type C, an EA with a TEF distal, this occurs 80 to 90% of the cases. That's why we rarely see the other types, because they're almost all type C. It's also known as the J type. It involves an EA with a distal TEF between the tracheal and the lower esophagus. Now, if you look at that, though, it's kind of scary, because every time the child breathes or cries, air can be forced across that fistula into the lower esophagus, into the stomach, and actually cause bowel proliferation. Not only that, but gastric juices now can cross the fistula back into the airway, causing pneumonia. So you've got to keep the bed up. So this is kind of like double trouble with that one. Type D is an EA with the TEF both proximal and distal. This only occurs 1% of the time. It involves an EA with both a proximal and distal TEF. So these babies show an EA on the x-ray with apparent abdominal air. Now they can aspirate both gastric juices and saliva. So you really have to double watch them, because now my gastric juices and my saliva can back up into the trachea. These babies are very, very sick. Type E is the TEF, and it's 4% of the cases, and it looks almost like an H, so it's called the H type. So look for it to look like an H, type E. The esophagus is continuous, so the saline sump would drop into the stomach with ease, and these infants show symptoms of aspiration with respiratory distress, especially during feedings, because there's a fistula between the esophagus and the trachea, so it just drops down into the trachea on its way down. All right, so what are the clinical manifestations? Like I talked about earlier, excessive salivation and drooling, and the 3 C's: coughing, choking, and cyanosis. So be looking for those. Apnea, increased respiratory distress after feeding, and abdominal distension depending upon the type. So nursing alert: any infant who has excessive amount of frothy slob in their mouth, difficulty with secretions, and unexplained episodes of cyanosis should always be suspected of having some type of TEF with or without an EA. Diagnosis is made by trying to pass an NG or gastric tube, and that will help you identify what type a lot, because if you look at type A, if you look at type B and C, and actually D, if I go to drop the saline sump on that on those, it's going to curl up. Now on type E, it's going to go straight on down into the stomach. But with the other types, when I do an x-ray, it will be curled up there almost like it's in a blind pouch, and that helps also diagnose. Treatment is prevention of pneumonia, continuous aspiration of the esophageal pouch, elevation of the head of the bed, NPO, and IV fluids. Surgical repair, they're going to go and do a thoracotomy with division and ligation of the TEF. So they're going to go in and ligate that fistula, and then they're going to go back and do an end-to-end anastomosis of the esophagus, where they just pull it together and attach it. All right, nursing considerations then. The nurse should be the first to feed, and it should be plain water, and they should be present when the parents are feeding, if the parents is going to do it, in case they have this TEF or EA. The head of the bed is at 30 degrees. You want to remove the source of aspiration at once. So if you ever suspect a child has an EA or TEF, you automatically make them NPO. They may be ended up with some G buttons. A G button is just a small button that pops open that they feed them through like a tube feeding. And IVs for 10 to 14 days. If they do go down and have surgical repair, they may have some choking with their first feedings, and you would want to make sure you teach that because, again, that may be fearful to the parent who has sent their child down with 3 C's and they come back and they're still choking some. So let them know that's a little normal for the first few feedings. Parent teaching post-op, of course, reporting bright red bleeding. It could indicate signs of active bleeding, maybe hemorrhage, that they didn't get it sutured well enough. Signs of infection, keeping pain controlled well. And if they've got any equipment, how to use it properly. Now, the good news is the overall survival rate is 85 to 90%. But they do have some long-term problems, such as esophageal dysmobility, where they have to go and have dilatations because of the strictures, and GERD can also develop. All right, that's it on that topic. So if you didn't understand the difference of A, B, C, D, or E, or the EAs and TES, please give me a email or a call, and I'll be glad to go over that with you. Hernias. There's a good chart on page 806 that goes over the different types. Congenital diaphragmic, sliding, and abdominal. Now, the one you're mainly going to see in children is the umbilical or the abdominal hernias, and these usually close on their own by school age. So I want you to look over that chart and be familiar with what they are, particularly if you look at 906, because a congenital diaphragmic hernia is bad because it has a protrusion of the abdominal organs through an opening in the diaphragm. So you can see we're going to get into breathing problems here and respiratory compromise and the inability to adequately expand those lungs. A sliding hernia is protrusion of the abdominal structures through the esophageal hiatus. So that's also causes problems. But again, the most common one you're ever going to see in children is an abdominal or umbilical. And most of the time, again, no treatment's necessary. It will heal on its own. Now, if it gets in causes strangulation or some other problems, or may need, for cosmetic purpose, they may do surgery, but otherwise, almost all of them will heal. All right, the last two things we're going to talk about are omphaseals and gastrocoesis. Omphaseal, this is on page 807 in your book, is a congenital malformation where the intra-abdominal contents herniate through the umbilical cord. Again, please go to Google and Google omphaseal and gastrocoesis images, and it will show you some excellent pictures. Omphaseal is a congenital malformation in which the intra-abdominal contents herniate through the umbilical cord, whereas gastrocoesis is a congenital defect of the ventral abdominal wall, where herniation of the abdominal viscera outside the wall carry through the defect. Most commonly, it's your intestines. Alpha fetal protein levels in both are going to be elevated, and it's going to be diagnostic by an ultrasound. Now, you can see this in utero, but sometimes parents don't go for all their visits. If they do this and know they have it ahead of time, they will plan a C-section. Omphaseals, failure of the abdominal contents to return to the abdomen by the 10th week of gestation. And they're going to have a protrusion, and it usually does have a translucent-like sac over it, and the size of the sac is going to vary. Our main goal is to protect that sac from injury, to provide fluids, and then they're going to have surgical replacement of those contents, and you're going to watch them for signs and symptoms of complications. Now, with surgery, most of these heal without incident, and they can lead a normal life. Gastrocoesis, most of these involve the organs of the small intestine and the ascending colon. So instead of just the whole abdominal cavity being out, with this one, it's mainly the intestines. And there is no membrane covering. It occurs about 1 in 10,000 live births. A surgical rate is higher because there's less anomalies, or survival rate. Survival rate is higher because there's less anomalies associated with this type. Treatment after birth, they're going to have sterile gauze soaked in normal saline solution covered by a sterile plastic around that. Current trends are to suture what's called a prosthetic silo around the gastrocoesis defect, and that allows for return of the intestines into the abdominal cavity. And if you've never seen a prosthetic silo, I would Google that as well, especially for gastrocoesis defects. what they will do is put it around, and it almost looks like something you would put sausage or something in. And they pack it all in there, and then they twist the top, and they just slowly start twisting that down until the contents go back into the abdomen. They'll also be on a warmer. They can lose heat through the open sac. That's why they're on a warmer. They can lose heat through the open sac. They can lose heat through the open sac. And because they're on a warmer, think about it, they're getting sterile gauze soaked in normal saline because you're wanting to keep that moist. So you're going to have to keep those dressings changed more often while they are under the warmer. All right, that's it for me. So if you have any questions or any concerns, if you'll get back with me, I'll be glad to help you. Thank you, and have a great morning, day, night, whatever it happens to be for you. See y'all later.